so we were all on the same page, right? Door to needle time is the patients arriving to the emergency room door and how long it takes from them to cut from that door to the time that needle is put in to get the IV Alteplase. And for endovascular therapy, there's a door to groin time. So how long it takes to get that needle in to puncture to get ready for the procedure. So we'll focus on the DTN, or door to needle time, which you guys already answered. You want it within 20 minutes. So I'm going to skip this. The American Heart Association does require, and the stroke guidelines require, door to needle time within 60 minutes, but we all heard that's not good enough. And Target 2, which is an American Heart Association National Quality Initiative, is really going to be looking at how much of the time we can get to 50%, as 50% of patients getting a door to needle time of 45 minutes. But the Right Care Initiative, I might have gotten the year wrong, and Helsinki, the group in Finland, was able to get to 20 minutes. So how did they do that? So they basically took these 12 measures, which I don't know if they project well, and over a decade implemented quality improvement through a number of initiatives that have been done at Kaiser and Stanford as well now. And so some of those included pre-notification of the hospital that, hey, you have an acute stroke patient coming in, so that the team could get ready, the CT scan could get cleared, and you can sort of already start to get a story of what's going on. Next, we were able to, as you heard, bypass the emergency room bed and get straight to the CT scanner so that we could get in right away with the IV and labs and imaging right there in the CT scanner suite. And then next, we were able to have the neurologist really interpret the imaging right there. Don't wait for a radiology report. You know what you're looking for. You're looking for no bleed, so you can give the IV Alteplase. When we talk about CT angiogram and CT perfusion, which is multimodal imaging, more advanced imaging to help identify large vessel occlusions, the ones that are amenable to the endovascular therapy, those are important to identify. But if you were to wait to make your TPA decision until after that, you're automatically adding about a 20-minute delay. That's actually what the Helsinki group found. So making sure you prioritize the non-contrast head CT for patients where you need to make a decision about IV Alteplase is so important. And then determine whether they are large vessel occlusion candidates if you're able. And so these are the types of measures and different interventions that Helsinki did. And it's what you've sort of already started to hear that we've been doing. And this is a quote straight from the original paper. Do as little as possible after the patient has arrived to the emergency room and as much as possible before that. And so for all the work of the stroke awareness group and pre-hospital notification, all the work that Kaiser's doing with telestroke, these are the kinds of interventions that are also very important. But now we're going to focus in on once you get to the hospital. So at Stanford, we use this design thinking that Arnie's group kind of teaches and said, what are those minimum number of steps that need to happen in the hospital? And this was published last year in Radiographics, but basically, these were just the basic things that needed to happen. Down to the granular, you have to register the patient, you have to call the code, transport the patient to CT. These are for walk-in patients, so they were some transport, or transport from wherever they came from. Identify the patient with the wristband, because that was a barrier, that patients weren't getting their wristbands, and so they couldn't get their CT scan. Check their glucose to rule out mimics, get their weight so you could order the TPA, and start the scan. And this was posted, this visual aid was posted around the emergency room and with the CT scanners, and it really helped. And that guy is our BFAST Bob. I don't know if you've seen Stanford's BFAST reminders for patients, but we decided to use that graphic. And so we said, okay, let's really look at the process. How did we come up with that? The process on the top was what used to be. See all the steps? We realized we don't need that, so let's just get rid of all those. And then come up with this more streamlined process for both patients that are pre-notified to the emergency room by paramedics, as well as patients who walk in the door. Those walk-ins, actually, they're pesky. You don't get to know about them before, and so it's hard to prepare for them. And we realized that our median door-to-needle times were really being affected by those walk-in patients, and we really had to make interventions focused on them, separate from the ER pre-notification. And that's an important step I encourage all of you to do at your hospitals as well, because they might be slowing your time down. And so what happened? I'm going to show the 45-minute. I don't have the 30 minutes that Dr. Klingman showed, so we can't, compete. But basically, if you look at the door-to-needle time, less than or equal to 45 minutes, how often are we able to get 50% of our patients there. And you can see that so the first intervention in Q3 of 2013, that's when we started EMS pre-notification and bypass of the hospital bed to the CT scanner. Okay, so we started to really make a jump up where we were starting to get 30% of our patients under that 45-minute time. But we could do better, and that's when we realized the part about the walk-in patients. So then in 2014, 2015, we really made efforts with that BFAST-BOB guy and the critical acronym and all the implementation work that all of us are familiar with. And there we were able to bump up and really consistently achieve these times. And we're continuing to iterate and improve every day. And I think that we'll be able to get to 20 minutes. Right now, if you just look at absolute median door-to-needle times, in the last year, we really have brought those down. So down at the end, you can see just in the first quarter of 2018, our median is 22 minutes. That means a lot of the time, or half the time, we're also getting under that. And so we have these buttons with BFAST-BOB and pins for our providers that participate in rapid stroke codes. And this is the last month. Those are our times. So we're really excited about that. And what about the extended windows? So you kind of heard the basic framework from Dr. Klingman that there were these two trials that essentially extend the window for endovascular therapy out to 16 or 24 hours, depending on the criteria used. And I'm just going to say, without going into all of the science, that I take this as a message not about necessarily saying, okay, does this person check off all these 16 criteria that were used as inclusion criteria in the research protocol. It's a message to us that with the right patient selection and the appropriate imaging, more people can get treated. And at Stanford, we don't necessarily follow the absolute law of the trials. We take the message that we need to use this fancy software, this rapid software that makes interpretation of perfusion imaging easy, and identify patients that have small areas of stroke that are already dead, the core tissue, and large areas of penumbra, or area at risk that's not yet dead, and save those patients if they meet certain criteria. And so how do we deal with that? And how do we deal with that in the context of us aggressively pursuing door-to-needle? Arnie asked the question, do we not sweat it for those patients? Do we have more time? What does it all really mean? And so if you take out the IV TPA patients, what do we do then? So first, I mentioned you have to get imaging, right? Shoot, I think I told you the answer. But let's just go through this anyway so we know. I wanted to define the imaging for you. Which type of imaging is needed in the extended window? A non-contrast head CT, which is what we already get to determine if a patient has a bleed and if not is eligible for IV Alteplase. So a non-con head CT to figure out how much tissue is already dead, because you can kind of tell that also. A CT angiogram, which is given with an IV to give dye and measure, to take a look at the blood vessels and identify the large vessel occlusions. A CT perfusion, which is more dye and more radiation, more contrast, to figure out that tissue at risk. We can actually measure what is the penumbra, what is the area at risk, what is there to save for the patient. Do we need all of it or none of it? So I think people are answering. We might not be surprised, but we'll just try. Okay, where's the other 10 people? Come on, guys. They went to get coffee, maybe. Okay, there you are. 2 more seconds. All right, good. So all of the above. That's absolutely right. To determine whether a patient is eligible for treatment in the extended window, you need to have all 3. You need to have what we call multimodal imaging, and a CT is good, and MR can work too, and the diffuse trial primarily, diffuse 3, which we ran out of Stanford, primarily we had most of the patients getting CT perfusion. All right. So how do we make it work? So simultaneous, we kind of had the inside scoop. So while other people were waiting for the American Heart Association guidelines to change, which as you heard changed the very next day, we knew what was going to happen, or we thought we knew. And so I started working on this process in the earlier part of the year so that we would be ready to go live in November with this extended window protocol. And so how does it go? You have a stroke patient in the field, and they come to the emergency room. And they may come via the EMS, or they may actually walk in. It's hard to know. But wherever they come from, what happens next? So we know that in the IV Alteplase window, the traditional window, this is probably what's happening at your hospital, some form of this. The patient comes in, there's a non-con HES-CT that gets performed. You ask yourself, is this an ischemic stroke? Rule out hemorrhage. And then depending if they fit the criteria, you administer IV Alteplase. And that same patient, then you might ask yourself, could they actually benefit from endovascular therapy? So these are the patients in that early window, first of all. To determine if they have a large vessel occlusion, they also need a multimodal CT to kind of figure out if they have an occlusion. And then if they do they fit the selection criteria to get endovascular therapy, EVT? And so this is what's already happening probably in most of your hospitals, and some of you might have a transfer to a hospital that can do this somewhere built in. So what about the extended window? So I've changed it to the patients that need endovascular therapy. So we heard from Dr. Klingman that we already had the evidence that certain patients in the 4.5 to 6 hour window were already supposed to get endovascular therapy, but now we have that 6 to 24 hours available. So just putting them in one block, you can see that the process is unchanged for the top line, and that those patients, then you need to rapidly get them to a multimodal CT and ask the same questions. So really, your process doesn't have to change a lot. You just have to get better at your existing process and figure out a way to get that multimodal CT available quickly. So you might ask yourself, okay, 4.5 to 24 hours multimodal CT, but don't I have more time for those patients? So does the CT really have to be done rapidly? Yes, get it as fast as possible. Maybe take your time as long as you just get everything done within the 24 hours. Or no, just take your time. CTs are expensive. Don't worry about it. Don't sweat it. So people are answering. So we haven't given you the answer to this, I don't think. All right, couple more seconds. Here we go. All right. Yes, everyone knows, get it as fast as possible. And I agree with that. But that's a good question that people brought up. Why were the number needed to treat in the DAWN and Diffuse 3 trial 1 and 2 better than any of the previous trials? Why is treating patients in the longer window, where the median door-to-needle time was 11 and 12 hours in the two trials, why were those patients doing better than ever before? And Dr. Klingman mentioned, the devices are better, the selection was better, and it also has to do with the pathophysiology of these patients. So this is what the multimodal imaging looks like, the perfusion imaging. And here's a patient, a real patient, at time equals 0, that's just the acute point when they hit the door and get their scan. And this is perfusion imaging. So you're measuring how long does it take for the dye to reach the brain tissue, how many seconds. And the warmer colors is slower, longer, tissue at risk, and the cooler colors are it's getting there quickly. So in this patient, there's a spread of slowness occurring on the left hemisphere, and the red part is the really probably already dead tissue. It's very, very slow there, more than 12 seconds. And the remaining colors are tissue at risk. So it's slowed compared to the other side, but it's not yet dead. So this is the holy grail of acute stroke care. This is what we have to save. And at 3 hours, without therapy, it all just died. It all became red. Okay? So just in 3 hours, so let's say the patient came in at 16 hours, and you are in the 24-hour window, and then there at 19 hours, you lost your opportunity. And here's another representation. So diffusion-weighted imaging, this is MRI, but it's a way to measure how dead the tissue is. So the acute stroke is the kind of pinkish, whitish areas. And then actually, this is actually at 5 days, not 3 hours, sorry about that. But basically, way out at that time point, that's the final infarct burden. It all died. And that patient was obviously very functionally impaired. And so I bring this up because I'm trying to make a point, and I guess I don't have that slide there, but every person is unique. The rate that their brain tissue is dying is different. It actually depends on what's called collateral blood vessels, or small branches that help your brain get blood and perfusion when the large vessel is occluded. And so when you're in the field or when that patient walks in your door, you don't know who's going to have better collaterals and a slower growth and who's going to go rapidly and get from 0 to 3 hours all the tissue dead. And so you need to move fast regardless, because we don't yet have the biomarker or the metrics to rapidly in advance know who's a slow grower and who isn't. But it's probably we were capturing the slow growers in diffuse 3 and DAWN, and that's why we got better outcomes. So with the right patient selection and rapid time to image, you will get good outcomes for the fraction of patients that are going to get endovascular therapy. And you shouldn't lose sight of the majority of patients that you're hoping with all your pre-hospital messaging and education and other initiatives are going to get to the hospital earlier for IV alteplase. And so the other question is, can we essentially, so then what do we do for these late window patients? Do we image everybody? But many of you deal in cost and worry about that, and I do too, and we can't image, we can't do CT, CTA, CT perfusion for every single patient that might have a stroke syndrome that walks in the door, even up to 24 hours. You can imagine how many scans that is. So what the American Heart Association guidelines and what we did was really say, what metric can we use to stratify these patients? And so we use a metric of NIHSS greater than or equal to 6 as determined by the ER physician, and added that in as a step before triaging who goes on to get the endovascular therapy and the advanced imaging. And so just to remind everyone, and what we did was we actually measured, since we started this protocol in November, in the last few months, you know, Jeff mentioned, we don't know exactly how many patients this is, but this is our small experience at Stanford so far, of those where an extended stroke window was called. We don't have what percentage those are of the initial screening, but once the ER physician did their NIHSS greater than or equal to 6 and called an extended stroke code window, we actually had about 18 of those patients in the last few months. Of those, 8 had an ischemic or hemorrhagic stroke. So they had some stroke diagnosis. So that's about 40% where we were getting good diagnoses and needed acute neurological care. And we activate the stroke team right away with that extended stroke window. And then of those 8, 2, or 11% of the whole 18 people pool went on to have a large vessel occlusion and get treated with a good functional outcome. So this is just a small experience where already 2 patients were helped. That might seem small, but those people's lives are so much better because they are ambulatory and nearly back to normal. And in conclusion, I'm getting the stink eye from everyone. In conclusion, implementation of innovative systems change does reduce door-to-needle time like it did at Helsinki, Kaiser, and at Stanford. And we will get more stroke survivors and less disability because of this. The extended window, and I would say more broadly, the endovascular therapy eligibility does require rapid door-to-imaging, which is identical to the door-to-needle process. And so process improvement remains urgent, necessary, and life-saving in all cases. And faster is better, so that, don't forget, as Arnie mentioned before, time is brain still rules. Okay.
So, 2 things. First of all, we're going to skip the question period in order to move things along. Secondly, I want to thank the stroke panel. And also, for future panelists, I want to say, no matter how passionately you feel about your topic, it's very important for all of us that you stay within your time bounds.
That's why the installation is good.
Well, that's amazing work that you're doing with the app. We're actually trying to do an app or a program using...
So that was very complex, and as you could see, the time sensitivity was really important there. And at the Right Care Initiative, we've been focused over many years since the onset of the initiative on intermediate outcome measures of diabetes, blood pressure control, lipids, etc. And even though these are seemingly more straightforward than what you've just seen, I think what I'll show you is the trends of health plans in the state over time since the initiative launched. And you could see that we still continue to have a lot of challenges. And I hope that this motivates you for continued action in this area. So as you can see here, this is performance over time among commercially insured patients for all adults blood pressure control in the state. And as you can see, I'd like you to pay attention to the California average and the national average. Essentially, what these data show is that the national average and the California average have been pretty stagnant over the initiative, and actually in comparison to the 90th percentile of the national performance, which has improved over time. So we do, even with all the gains that we've had, the rest of the country, the top performers continue to move fast in terms of improving their performance. And so even with all the gains in blood pressure control, we still don't have breakthrough improvements like the 90th percentile in the nation. I wanted to point out that Kaiser Permanente North continues to lead the pack, over 80% of their members under control, as well as Southern California. You can also see the purple line with Sharp Health Plan, as Hattie mentioned, really making strides in recent years on this measure. Now, if we turn to the same measure, but isolating to only diabetic patients, we see this is a bit more challenging. But we do actually have some top performers in this area. We have the Kaiser Permanente medical groups, and we also have Sharp Health Plan rising to the pack over the 90th percentile in this reporting period. As you can see here, California has done better than national 90th percentile change over time, and better than the national average, which I think nationally we're having challenges in controlling blood pressure among diabetics. So this bodes well for us in this initiative. We're doing better than the national pattern. However, when we look at blood sugar control, I think this is where we continue to have lots of challenges in the state. As you could see, over time, California's average has dropped, as well as the proportion that have A1C below 8 has dropped, as well as the national average. We didn't drop as much as the national average. But this continues to be an area where performance is pretty tightly packed. It's really compressed among the health plans as compared to blood pressure, highlighting that this is a challenge for most health plans. And again, you do see Sharp Health Plan along with Kaiser North at the top of the pack this year. When we look by region, and highlighting the challenge of blood pressure control, when we look at the 3 University of Best Practice communities and the medical groups participating and involved in those initiatives, in the Sacramento group, you could see that the range of medical group performance in performance year 16 ranges from 70 to 61% of diabetics with blood A1C under control. And this is a 9-point spread in the community, which suggests that this is a common problem and challenge for all the medical groups in the Sacramento area. Similarly, but a bigger gradient is in LA, where we have many more heterogeneous groups, lots of IPA groups. And you can see that Newport Physicians, UCLA Medical Group, Healthcare Partners Medical Group, these more integrated groups perform better as compared to the IPAs who are lower performing on this measure in LA. One thing to note is that within Kaiser, even though we see really good performance across these measures, there's heterogeneity within the Kaiser system. And as you could see, Kaiser Southern California here on this measure does not lead the pack in that region. Similarly, when we look at San Diego, who has the longest history in the Right Care Initiative, we could see performance really from 76% to 61%, with most of the integrated groups performing very well and more of the loose groups not performing so well in terms of the IPA organization. So even with a community that's been working on these measures for a very long time, we do have fairly high variation in San Diego on performance on this measure. I wanted to highlight a couple of takeaways from the patterns that we've seen over time. The first one is that blood pressure has improved over time in the state, and Kaiser Permanente continues to lead the pack. We see some gains in Sharp Health Plan making big strides in this area. Controlling blood sugar, however, has been a really big challenge for all medical groups in the state, and we could see that the regional variation is pretty tight. Third, medical group performance on A1C control is a very narrow range, as I mentioned. And then finally, IPA groups tend to struggle across the measures in our Right Care initiative. I think the final point is that all of you in this room are here to contribute your best practices, what's worked for your organizations. And I think that the patterns of the data in terms of medical group performance suggests that we can continue to collaboratively learn together. So thanks for your efforts today, and I look forward to engaging discussions the rest of the day. Thank you.
Parag, I'm going to do first. Congratulations. Well, good morning, everyone. Can you guys stand up? I want you to get all that stuff you learned about stroke. I want it to soak in, so soak it in. Take some deep breaths. Okay, that's enough. I'm Janet Wright. I am here on behalf of the Million Hearts team, and I'm, again, so appreciative of the chance to be in the room and to soak up this learning with you. I'm here to celebrate your birthday and also to put a marker down for your 20th birthday. I would love to be here for that. I would say that I don't have any disclosures, but that's actually not the truth. I practiced cardiology for 23 years north of here in Chico, and when you do anything for a long period of time, you hopefully get good at it. I don't know how good I was, but I did begin to feel that I saw patterns. And one of the patterns was I wasn't a very good change agent for my patients. I began to see them, see into their future, whether it was a new patient or someone I'd taken care of for a long time, that if we were lucky, we were going to meet again in an emergency room or a cath lab, because I wasn't able to help them adopt healthier behaviors, even when it comes to just taking medications regularly. I had serial conversation, the same conversation over and over again, and yet didn't see change. I had had many, many opportunities to lose someone because of not getting that behavior change, or because of not creating a compelling argument, or really living in a place that helped support healthy behaviors. We saw over and over again events. So my disclaimer is, I have a thing about waste. And Arnie called it, I don't know if Arnie's still in the room, Arnie called it missed opportunity. I like that better than waste. But what I hate is knowing what works, but not seeing it happen everywhere for everybody. And so when Million Hearts came along, I knew immediately that I wanted to jump on board. So for those of you who don't know, Million Hearts has been started out as a 5-year initiative co-led by CDC and CMS. And the idea there was to bring together the public health and science expertise and the community roots of CDC, but marry it up with the payment and policy heft that comes out of CMS, but to recruit partners in the public sector and the private sector to focus on a common goal and to light a fire under that by giving it a 5-year time frame. So from 2012 to 2016, we had our first 5 years. And the goal was to prevent 1 million, we said heart attacks and strokes, but we're actually counting other events that would likely be impacted by better prevention, both in the community, the public health aspects, and in the clinical environment. Because we were trying to get a lot done in a 5-year period, we focused on only those things with a strong evidence base, and we actually did modeling to figure out what would be the things that would produce 1 million fewer events in that 5-year time frame. So in our first 5 years, we focused on the public health side, sodium reduction, elimination of trans fat from the food supply, and reducing tobacco prevalence, all big levers to pull from a public health standpoint. Over on the healthcare side, we focused on aspirin, blood pressure, cholesterol, and smoking, A, B, C, and S. And yes, there was advocacy for diabetes and exercise and adding additional letters to the alphabet, but happy to answer questions about why we didn't go that way. So what the heck happened?